after 8 cycles, she had a radiographic complete response.
Can we do T-DXd up front for 6 to 8 cycles? I think it's also important to mention that in DB09, as we all know, it was continuous T-DXd pertuzumab exposure, and that the average time those patients were on therapy was somewhere between 2.5, 3.5 years. So I think there is a con there that we have to discuss with patients, right? They didn't go on to a maintenance strategy like Cleopatra, and I think that that's something we have to also take into consideration.
Absolutely. And we're hopeful that we might see things like that emerge in the future, especially when we look at these patients and the depth of response, these patients achieving a CR, can we follow those patients with ctDNA or some other genomic predictor to tell us which are the patients that are likely to get those long-term durable responses, and maybe would be just fine with a maintenance strategy with HP alone or whatever that looks like for that particular patient. And I think that's what we're really excited as kind of the next step to see if there are patients that becomes a viable option for in the future.
I think that's so exciting, individualizing therapy for HER2-positive disease in the metastatic setting, that we have all these options. Are there situations where you sort of this de-escalation strategy that you mentioned? So certainly Cleopatra, we gave on average, 6 to 8 cycles of chemotherapy and then sort of dropped back to the Herceptin and pertuzumab. Are there certain patients where you might foresee doing a similar strategy with DB09?
I've actually done that in my practice already with a very extensive discussion with the patient that there's absolutely no data at this time to support that, right? But I had a young patient in her 40s. She's single, working full time, trying to be, very active. And she had been on T-DXd for 2 years. A solitary liver and a solitary bone metastasis, both biopsied, so both proven to be metastatic disease, with complete response by imaging. And just with the fatigue and, everything kind of weighing on her, we had the discussion and we made the decision together we did an MRI of her brain. We made sure we didn't see any, CNS disease. She has a CR. She has for more than 12 months, and that's been maintained. And so we are doing trastuzumab maintenance, and we're watching her very carefully with scans. And she's the kind of patient that I know will tell me if she were to develop any sign or symptom suggestive of progressive disease. And I also trust that she's going to be very compliant with her surveillance scans. Certainly no data, but these are strategies that might make this a more viable option for a majority of patients in the future.
I had a similar patient, Anne, she was young, wasn't tolerating things well. So the first thing we did is sort of drop the pertuzumab. She did a little better, but still was struggling. And after 8 cycles, she had a radiographic complete response. And actually, we looked at molecularly, had a complete response as well, and are sort of opting to de-escalate and follow her too. So there's a lot of now shared decision making in our clinics. It takes a long time, but I think it's great to have so many options.
I think we can feel supported in that strategy too, though we don't have the results at all. But the Demeter study is a phase 2 study looking at exactly that strategy. Can we do T-DXd up front for 6 to 8 cycles and then move on to a maintenance strategy? And I think as complicated as maintenance is now, especially with the next discussions we're going to have surrounding patina and HER2-CLM05, I think we can feel that that's a relatively good strategy, but I think we ultimately need the data to support it.